Now I'm going to present our next speaker, which is Dr. Hernandez. He is originally from Puerto Rico and has worked for 31 years in the health and human services field, developing, implementing, and evaluating culturally and linguistic intelligent youth and adult health support programs. Also, he has many years of experience in delivering addiction counseling and clinical supervision for professionals in the field. Without further ado, Dr. Hernandez.
Perfecto. How was lunch? Was good? If it was good, we'll take credit for it. If it wasn't that good, see the university. Thank you for returning after lunch. And you're right, that light is kind of bright on the eyes. A few things. I want to thank the university for hosting us once again, the dean and other folks who've welcomed us here. Thank you very much for the opportunity to present, to share with you some of the knowledge that we have and skills and resources, that sort of thing. And I want to acknowledge Dr. Sayas and Dr. Torres, who went before me. I'm going to be talking about prevention of substance abuse and mental health within Latinx communities. And before I say that, I'll say a couple of more things about myself. Yes, I'm originally from Puerto Rico, but I live in Massachusetts. And I've lived in Massachusetts since I was 5 years old. I have a strong connection to the island, though. I have a home there, and so I go back and forth. My background is in public health, and I'm a certified prevention specialist and a certified and licensed drug and alcohol counselor at the reciprocal level. And yes, I have a PhD, but I also have a GED, and my GED I got in prison. And it was more difficult to get a GED in prison than to get a PhD out here. And so I am a person in long-term recovery, and what that means for me is that I haven't used a drug, including alcohol, for the last 33 years. December 20th was the anniversary there. And thank you, muchas gracias. What that has enabled me to do is to be a productive member of my familia, my community, and to be here present today and to do this type of work. I'll come back to why I introduce myself the way that I do a little bit later on. I have slides, so I'm going to work through some of these quickly, but I had a little huddle with the table and the colleagues who were presenting after me, and we brought permanent markers. And you're asking why. Fall asleep and you'll find out. We will take care of that. Some people will be looking at you strangely, and you'll say, what? Maybe something on your forehead. At any rate, so I do some work with IRESA, and I also do some work through the ATTC network at Brown in Providence, Rhode Island, and I'm a senior consultant with the Massachusetts Department of Public Health, focusing on issues of recovery and disparities. And so I'm going to say some things that are probably going to make some people feel uncomfortable. My response to that is good. Nothing has ever changed unless we're made to feel uncomfortable. So if you feel any type of way, there are plenty of social workers in the room, right? And so we can get hugs and support from other folk, but there's some stuff that needs to be said, I believe, right? And so history and context matters. You'll know that most of my slides are non-traditional. I come at this from a different way. And so we should understand that when we think about mental health and substance use disorders, there are silos that have been built, right? And so there's mental health probably on one side of the building or another side of town. Somewhere else are health services, health and human services somewhere else, and substance use disorder services somewhere else. These systems don't regularly speak to each other. And even if they're in the same building and sometimes in the same office, we don't see ourselves interconnected with prevention, intervention, treatment, and recovery supports. And that's problematic for many different reasons, and it impacts outcomes for the people that we are responsible for treating. Our field has been founded on punitive approaches, and there's plenty of research that points to this. There has never been adequate funding for prevention, intervention, treatment, or recovery supports, but when we think about that continuum, most of the funding goes where? it goes to treatment, right? Now, I'm not saying that treatment doesn't need funding. It needs funding and more funding, but also we need to think about the continuum. People get better when we do, and communities get better, when we do prevention, intervention, treatment, and recovery supports across the board, and we just don't work in a silo. And so it pleases me that there are many social workers in the room, because we need to continue to think about what that looks like in practice. In my view, and many other folks who've studied this, we have a flawed design in terms of how we treat people and how we engage people with substance use disorders and mental health issues. If people have a relapse or reoccurrence of symptoms, historically, we've kicked them out of treatment, we've kicked them out of care. And we've done that to the detriment of folks and entire communities, right? And so that is still happening today. It shouldn't happen, but it's still happening. And so you might be able to pick out some spaces and places where that is not happening, good, but that is not the norm across the continuum. We have criminalized mental health, and we have criminalized substance use disorders. We have sent people away, and I'll come back to this theme a little bit later, but that's what we have done as a system, as a country, to the detriment, again, of individuals, families, and entire communities. And we can't stop there. And it pleased me a great deal to hear this morning the remarks, the welcoming remarks grounded in issues of social justice, because we have also criminalized color, right? And so we see disproportionate number of people of color incarcerated in this country that have issues with mental health and substance use disorders. And by the way, that includes poor whites who have been subjected to that as well. Have you been to the conferences with the mantra that says addiction and mental health don't discriminate? Have you been to those conferences? And many people start clapping. Stop clapping. Right? Because that sounds like a really good tagline, right? But the reality is that individuals discriminate, that systems discriminate, and that our system has been designed primarily for white heterosexual males. And if you're not a white heterosexual male, then you will have more difficulty getting into that system. That doesn't mean that some white heterosexual males don't get in or can't get in, but I'm saying that when we look at issues of access and quality of care, that looks different depending on who people are. Remember I said feeling uncomfortable? Well, some of those statements make people feel uncomfortable, but they are a reality for people on the ground. And so, moving forward, we should think about issues of disparities, right? And we're talking about a racial, ethnic, or behavioral health outcome that is seen to a greater or lesser extent between populations, and that these things are particularly linked with socioeconomic and or environmental disadvantage, right? So that's what we understand about this definition of disparities. I know that you know this, but it's just to anchor the conversation moving forward. When we think about substance use disorders and Hispanics or Latino populations, there's some things that we need to understand, right? Combined 2003 to 2011 data indicate that Hispanics aged 12 or older were more likely than non-Hispanics to have needed substance use treatment in the past year. Hispanics who needed substance use treatment were less likely than non-Hispanics to have received treatment at a specialty facility, right? Among Hispanics needing but not receiving treatment, only 5.6% perceived a need for treatment. This is where most of our focus goes to, because we tend as a society to blame individuals for the conditions in which they live, because we believe in this thing about personal responsibility and the pull yourself up by the bootstraps mentality. I'll come back to this a little bit later on. The use of opioids and related deaths continues to be an issue for Hispanics and Latinos, and again, I'll come back to this in a couple of moments. And it's not just opioids, it's other drugs as well, right? Let me give you some stuff around mental health, again, to ground the conversation. 15.7% prevalence of mental health disorders among Hispanics or Latinos in the US. When we think about common health disorders, we're talking about mental health disorders, we're talking about generalized anxiety disorder, depressive disorders, PTSD, and substance use disorders. Also, it's important to know that Latina high school girls have highest rates of suicide attempts in the country. That is concerning. If we think about what Dr. Sayas and what Dr. Torres talked about by way of the impact of trauma on young people in this country, and in this case, thinking about Hispanics and Latinos, that should be really concerning to us as well. As a community, Latinos have less likely to seek, as a community, Latinos are less likely to seek mental health treatment due to stigma, discrimination, lack of information, and other factors that are present at the community level. And there's a lack of access and poor quality of care that contribute to disparities as well. How many of you think we have an opioid crisis in the country? Or that you have one here in Colorado? Quite a few people, when we ask that question. I disagree with you. I disagree with you for the following reasons. Because we have a crisis in health, in mental health, in education, at the community level, in employment opportunities, in affordable housing, in substance use disorders that doesn't include opioids. It includes methamphetamine and cocaine and alcohol and all of those other things. More people die of alcohol-related deaths than any other drug in the country. And we have a crisis in the criminal injustice system. We have a crisis there too. So what do? When we have a myopic view of what the issue is, then we have myopic solutions to what the problems are. And so if we keep repeating the mantra, what we have is an opioid crisis, then we will get outcomes related to the policies that come out of that mantra. See, the issues facing communities, and not just Hispanic and Latino communities, are more complicated than just opioids. They're way more complicated than just opioids. Opioids have to be talked about in many different ways. Now that I told you that I don't think we have an opioid crisis, let me give you some numbers that contradict myself, because I'm known to do that too. Every day, about 130 people die in the US, which means today about 130 people will die. More than 70,000 died in 2017, opioid-related deaths, right? Approximately 350,000 have died thus far in the US. And in Massachusetts, the state where I live and practice most of the time, about 2,000 people died in 2018, about 2,000 people, right? Additional data. So why are we calling this a crisis now? Why do we declare a crisis now? Because, go ahead. You see, the crisis, we have been living in a perpetual crisis. Now, when young, white, affluent kids start to die, then we call it a crisis. And then we name it a public health crisis. But before then, we didn't call it a crisis. Again, these are some of the things that make people feel uncomfortable, but we need to anchor the conversation in that reality. If we don't do that, and you want to work with Hispanic, Latino, Latinx, or even African American, Native American communities in this country, and you don't acknowledge that from the rip, from the get, you will have very little buy-in, because people say you don't understand us. And we don't trust you when you come into our communities with saying now you have a crisis because now a different population is dying. And what does that look like by way of outcomes, you see? Those are uncomfortable conversations, but if we don't have them, we perpetuate disparities, and people will continue to die. And so what we have are disproportionate impacts, and I'm going to give you a quick case study of Massachusetts. 2017, 8.3% decrease in opioid-related deaths in the state. Do you think that that's a good thing? Anytime there's a decrease in deaths, it's a good thing, right? 2018, 4% decrease. One of the very few states where opioid overdose deaths has gone down in Massachusetts. Do you think good work? But some of us went, wait a minute, we need to look at that data a little bit closer. Because this was what the governor was saying, what the Secretary of Health and Human Services was saying, what the Commissioner of Public Health was saying, and they all had these little nice press conferences. When we got into the data, this is what we found. That between 2015 and 2017, opioid overdose deaths for African Americans went up 83%. That they went up 100% for Latinos, Hispanics in the state. So the question then becomes, is this is getting better for who? And under what circumstances? You see, we need to get past the sound bites and what people want us to listen to, and we need to dig deeper in terms of what's actually happening at the community level. And I argue that when we see communities as disenfranchised and broken, we do a disservice to those very communities, because there are many of us who live, work within those communities that don't view our people as broken and in need of saviors. There needs to be a different relationship in terms of how we work with communities. If this is not alarming to you, I don't know what is. It is to us, because these are our people dying. These are the members of my family that I put into the ground. My sister, a couple of cousins, and I don't know how many friends. But I've been to so many funerals that I'm reminded of what Dr. Torres was talking about by way of burnout, right? And those issues that we confront on a daily basis. It doesn't stop there. This is why the comment around who's affecting now becomes really important, right? Because we have a thing called mass incarceration. And if we're going to talk about mental health issues and substance use disorders and the prevention thereof, then we need to pay attention to issues of mass incarceration in the country. Whether people like it or not, or feel uncomfortable or not, this is a reality that people live. And I don't talk about this purely from the perspective of academia and research. I have lived this situation, and I have countless friends and family members who are currently living this situation, right? So in 1970, there were 200,000 people incarcerated in the US. Fast forward to 2019, and we have 2.3 million people incarcerated in the US. If you add the 5.5 to 6 million people who are under house arrest, probation, parole, that sort of thing, it comes to about 10 million people. We have the largest prison population per capita in the world. USA, number one. That's a place where people can say USA, number one, right? But that's the reality on the ground. Now, most people who work with communities want to point fingers at individuals and say, you can get out of that. If you are like Janer, you can come out of that. And so they try to drag me in front of a stage to talk about, I have a PhD and I have a GED and I got it in prison and now I'm good and I'm doing this. Because it sounds good, right? That sounds good. But that puts the onus on the individual. And I believe in personal responsibility, but I think that there are other things here at work that created this reality for our people. And if we are myopic in understanding what the problem is, then our solutions will be blaming individuals for the misery in which they live in. And it's a little bit more complicated than that, right? So we have deliberate policies, and we know what they are. We know where they came from, right? The war on drugs. The institutionalization of mental health hospitals across the country, the criminalization of behaviors, the difference between sentencing in powder versus crack cocaine, mandatory minimums, no voting rights in upwards of 25 states, school zones, which they tack on an additional 2 years, right? In the city which I live, only 1,000 feet in that city is not a school zone. Those policies were designed to impact inner cities. Inner cities where most people who live there are people of color. 3 strikes and you're out. Massive prison construction. Privatization of prison and jails. Dr. Sayas and Dr. Torres were talking about this. If you're sitting in this room and you have a retirement account, a 401k or whatever other account, you probably have money in private prisons and jails and you don't know it. Because the people who move that money around for us, we barely know who they are. And when you get the statement, it doesn't say you're involved in the private prison complex, right? It doesn't say that. It has some funky name that says, yay, we're doing good, right? And then criminal offender records. We did a full circle there, right? Ensuring that if you have a criminal offender record, you have difficulty getting housing, employment, school loans at the federal level, and everything else, right? And then there are many other policies that were put into place. How many of you think that this system is working? No one raised their hand. I think it works to perfection. If I was sitting where you're sitting, I raise my hand and say, it works exactly the way it was designed to work. It's not that it doesn't work. These policies were meant to produce the results that it produces, not the other way around. So when we talk with people and we engage with people in regarding issues of prevention, intervention, treatment, and recovery supports, we better have a conversation about mass incarceration and what that looks like. If we add to this 2018 data that came out, the so-called plea bargains, 97% at the federal level, cases are pled out. And look at what it does at the state level, 94%. This is countrywide, right? This is national data. What does that mean? That means that people don't have due process. This means that people who are innocent plead guilty because they were coerced into pleading guilty. I have done a lot of illegal things in my time. And many of those times I needed to be in prison and in jail. I'm not a Pollyanna about that. But there were times that it wasn't me. But I was told by a public defender, they're going to give you 15. You want to take 5? What do you think you're going to do in that situation? Right? It's not that difficult to decide. Look at what this produces. Now we're talking about young male incarceration rates in 2018 between the ages of 25 and 29 per 100,000. For whites, 1,437, primarily poor whites. For Latinos, 3,892, almost 4,000. Look at what it does for African Americans and blacks, almost 9,000, 8932. If we're not appalled by this, I don't know what can rattle our cage. These are difficult conversations. And right now, we're in a place where we're having the conversation, and people from all sides of the aisle say that this is not sustainable. Some say because of the budget, some say because of human conditions. I'll take whatever argument as long as we get to work on these issues. Because our people are engaged in the system, but it's not just our people, it's the families of our people. It is everybody who's impacted by that, including those of us in this room. We need not to do anything else but follow the money in terms of what's happening right now. Again, myopic views of what the problem is, myopic solutions. So there's a lot of money going into healthcare settings. You've seen this, right? Hospitals, federally qualified clinics, right? There's a lot of money going in there because of the opioid crisis that we're talking about. Do they deserve money? I think that they do. As a matter of fact, they created a major part of the problem with overprescribing, right? So I think that they deserve to have money. Another place that's getting an influx of money is criminal justice settings. This is your sheriff's departments, your jails and prisons, and all of those spaces and places that have contributed to mass incarceration. Should they be doing something differently? I believe in that too. The other spaces and places that are getting money are community-based settings. Let me pause there and say this. Those are the places and spaces with the most experience and knowledge of how to deal with substance use disorders and mental health issues. I argue that because that is a reality. When our people showed up in emergency departments and in other healthcare settings, they were pushed away, not treated, and continued not to be treated decently. And prisons and jails, we know what they have done. Lock people up, lock people up, lock people up. If you know of a space and a place, and I know many, that are providing treatment, prevention, and all of those good things, good. But that's not the norm. We're nowhere near where we need to be. Who's getting most of the money? Healthcare settings and criminal justice settings are getting most of the money. The largest grants in U.S. history, 5 of them. And my state got the largest one, $89 million to deal with the opioid crisis. They're going very specifically to criminal justice settings and healthcare settings. I am not saying that they don't deserve to receive funding. What I am saying is what happens to community-based settings where there are people who look like me, speak like me, who have inroads and trust into communities. Why isn't money going there like it should be going there? That is a policy question that we should raise. It's not only that. We have a single focus solution. Remember what Dr. Torres was talking about? These new ideas that come into the conversation and people go like, oh, you know what that is? The majority of that money is going to do what? The medication-assisted treatment. So this is what that looks like. You need medication, you need medication, you need medication, you need medication. My whole table needs medication. Everybody needs medication. Single focus. Single focus solution. Like the magic bullet. I supervise a team of people who provide MAT, MAR, medication-assisted treatment, medication-assisted recovery, among them a group of doctors, nurses, recovery coaches, and that sort of thing. So don't take away that Janet Hernandez doesn't support MAT, MAR. But do take away this. Janet understands that there are multiple pathways of recovery and not just one. There are 23 million people who self-identify as being in recovery in the U.S., and only about 20% of them did it with medications. The other 80% did it utilizing other pathways. So why are we putting all of our eggs in one basket? And there's credible evidence for all of this. So we need to think outside the box. And we need to engage with communities that have experience, including the community-based organizations that I was talking about. And people get into rooms and get into trouble when they raise the issues that I raise in front of groups. I did a presentation recently at Harvard, and a few people came at me like, wait a minute, what are you saying? I said, no, it's not what I'm saying. The evidence says it. If you don't want to listen to the evidence, then don't claim to be data-driven, right? Again, we need to move away from single solution issues to issues that are way more complicated than that. Now, how many prevention practitioners are in the room? Can you raise your hand? There's a few. All right. I take it that most people in the room do not do prevention. So we know that there's such a thing as primary prevention, secondary prevention, and tertiary prevention. Wherever it is that you land in terms of doing work, whether that's at the policy level, at the macro level, or at the more individual level, or if you're working with people at the community level doing Narcan, doing whatever it is that you do to prevent the many issues that we have to work on, to ground the conversation in this prevention overview, right? Wherever it is that you see yourself doing the work that you do. Now, for us, for me, it becomes important that we then take a look at the cultural elements that are present within, something happened to my presentation. Okay, something happened to my button. We need to understand the culture, or cultures, plural, of the people in which we work with, right? So I'm going to shift a little bit from all of that commentary to some of the cultural elements that we know are present within Hispanic and Latino communities across the country, right? And the cultural elements that we train to through the mental health TTC, I'm just going to give you an overview of them, but just know that we have products of training that are based on data and research, well-researched curriculums that we deliver. So anyone interested, please come see us about those. But here are some. Latino communities are organized around the family, not the individual. So there's such a concept called familismo, which means that if we approach the community understanding issues of familismo and what they mean by way of behavioral change, what they mean by way of prevention, our outcomes will be more positive than if we don't, if we come at it from the individual perspective, right? There's this big issue of respeto, or respect. Dr. Sayas and Dr. Torres talked about issues of respeto. And respeto is not just awarded by way of a title. It is earned, right? And it's closely connected to personal relationships or personalismo. Those of you who are in social work, when someone asks you a personal question, for years we've been trained to say what? This is not about me, this is about you. Keep the focus on yourself and we're going to be fine. That is a huge crock of shit. Forgive my language. It is. Because there we are with our brilliant assessment tools asking people, how many times did you have sex? How many sexual partners? Was it anal sex? Was it oral sex? Was it this, that, and the other thing? Right? And we asked, how many bags of heroin? Did you overdose? This and 1,001 personal questions. Are you here legally? All of the questions that we ask. And then someone says, do you have any kids? This is not about me. This is about you. And people go, what? Carajo es esto? What the hell, right? There's got to be a give and take. And this is central to working with communities that have experienced marginalizations in the country. Trust and confianza go hand in hand with this, right? And then religion, spirituality, or espiritualidad. These are core elements within the culture of Hispanics and Latinos. And so if we don't understand them, if we don't incorporate them into the planning and execution and evaluation of our programs, we will miss the mark. We will miss the mark. I'm going to turn the conversation to a look inward. We, as social workers, as clinical people, that sort of thing, we're trained to look at the person in front of us. And a lot of the education revolves around that, a look at the people who are in front of us. There's an important piece that we need to take a look at, which is who we are and what we bring to those endeavors, whether that's prevention, intervention, treatment, or recovery supports. Have you heard or have you said, I am non-biased? I've said that many of times. I don't say it anymore. But you've heard the people who go around saying that, right? I am non-judgmental. Have you heard the people who say that? Who claim that? There's a lot of people who say that. I used to say it, I don't say it anymore. Treat others the way that I want to be treated. That's the golden rule, right? You know what the platinum rule is? Treat people how they want to be treated. Sounds good. I don't say any of that stuff anymore. I used to a great deal. And then my personal favorite is treat everybody the same. All of it is a huge crock of shit. This is meant for us to feel good about ourselves, right? Because are we biased? Of course we are. Of course we are. We either like some things and we don't, right? Those sorts of things. Are we judgmental? Are we judgmental? Some people might be saying, I'm not judgmental, Hanel. You're judgmental. You've been judging people all day. Yes, that's true. I judge things and you do too. The thing is that we don't want to admit to some things that are in our space and in our faces. How many 55-year-old Puerto Rican males in the room? Raise your hand. I doubted that you want to be treated like me, a 55-year-old Puerto Rican male. You're 55? Even if this room was filled with 55-year-old Puerto Rican males, we're not all the same, and we don't all want to be treated the same. So this whole idea of sameness and treating people, and have you met the people who are attracted to abusive relationships and those types of insanity? They're treating people the way that they want to be treated. Sometimes it's not the best thing to do either. Now, bottom line for me, treat people with dignity and respect. Meet people where they're at, right? Have some conversations that bring people in, as opposed to marginalizing people and pointing the finger in that direction. We need to look in this direction. Who are we and what do we bring? Because we have internalized bias and we have internalized judgment, and when we combine the two, then it's a recipe for disaster. A recipe for disaster. So the approach needs to be grounded in what? In cultural humility. Cultural humility incorporates a lifelong commitment to self-evaluation and self-critique, to redressing the power imbalances in the whatever you are, right? And whatever the population is that you're working with dynamic, and to developing mutually beneficial and non-paternalistic clinical and advocacy partnerships with communities on behalf of individuals and the defined population. This is not new. This is not new. But again, how many of us are taught to look in this direction? How many of us are taught to think about self-critique as a lifelong process? My mom taught me something very valuable around education. Said that education has nothing to do with degrees and going to the university or anything like that. It has to do with how you treat people. Has to do with dignity and respect. Some of the most educated people that I've met in my life don't have a degree, don't know how to read or write. And some of the most arrogant people that I've met in my life have all of the titles that I have after my name. As a matter of fact, I have more letters after my name than letters in my name. How the hell that happened, I don't know. But that's what we're talking about, right? So it needs to be grounded in cultural humility. I'm coming back to why I introduce myself the way that I introduce myself, because it has to do with issues of stigma. We need to get away from pathologizing human beings. Dr. Torres talked about this, in utilizing person-first language. These are not homeless people. These are people experiencing homelessness. These are not addicts. These are people in need or seeking recovery, right? These are not schizophrenics. These are people with a mental health issue. We need to get away from language that, again, fosters pathology that points fingers in directions of people. We need to get away from substance use and substance abuse. That's why we're using substance use disorders as a term to bring people in. And some people believe there's even problems with that term. We need to think about how we bring people in and how we treat people at the individual level, at the community level, and within families. There's something called cultural intelligence. We're moving away from this term on cultural competency because it denotes I know everything there is to know. And if you've been reading any of the scholars who've been writing about this, it's really fascinating work. Cultural intelligence is about the capability to relate and work effectively with culturally diverse populations. You can read the rest for yourself, and the slides will be made available. But what are we talking about? When we approach people, we should think about people as not broken and in need of saviors. We should think about people with strengths, communities with asset. The communities where I live, that's what I see. I don't see broken people. I work with people 25 years, 30 years in prison, 5 years, 10 years in prison, in and out of homeless shelters and that sort of thing. And I say, oh, you don't know anything. No, you know a great deal. You survived in a system that most of us would not last one day. The strengths and the knowledge that you have from being in that space and place is really powerful. It is about how we approach and understand these issues, right? Cultural proficiency. A set of congruent behaviors, attitudes, and policies that come together in a system, agency, or among professionals. Emphasis here that it's not just about us as individuals. You came here, you'll learn some things about culture and Hispanics and Latinos and Latinx populations and that sort of thing. If you go back to your agency and nothing happens by way of your policies and procedures, then nothing happened. We did not institutionalize that knowledge, and we know that we have institutionalized racism. That we've done really well at. You see? So this is not just about us, it's about the organizations that we represent and the organizations in which we practice in. I can't tell you how many times I walk into a space. I was invited to a help center in Boston, and as soon as I walked in, and the topic was culture, right, and issues of disparities. All of the Latinos were sitting in some tables, all of the blacks were sitting in other tables, all of the whites in other tables, and this funky table of people who always, mix it up, and they don't care what everybody else is doing. But that, to me, seems strange, right? In Boston, I went like, something's happening here. And when I started to talk about things, now I could see Latinos and African Americans in the body language, right? We're trained in reading body language, head shaking and grunting and all of that stuff. What I learned is that the help center had a policy that said you can't speak Spanish here. You see, they hired a whole bunch of Latinos and Hispanics because they know Spanish, but they can't speak Spanish in the space because then other people feel that they're talking about them. I have news for you. We are talking about you, but get over it. Just like you talk about us, but you don't say it in front of us because we understand English. It's the same deal. It's the same deal, right? But the mission is to do what? To do no harm, to serve people, to engage people, right? I make light of that, but that is serious stuff when it comes to treating the folks that we treat. We need a process of humanization. And when I say that, I don't mean the people outside of this room, I mean us in this room. I'll give you a quick example of what I mean and why I say what I say around issues of humanization. When you leave here today, you're going to get in your car or some type of transportation. You're going to drive through the city, and you're going to see some people standing at a streetlight with signs that say what? God bless you. Homeless, veteran, hungry, will work for food. Or one of my favorites I saw a couple of weeks ago, I need money for beer. That's cool. And then in New York City, I took some of my nephews last year at Times Square, and there was a guy there with a sign that says, need money for weed and pizza. Oh, shit, he got it right? You smoke some weed, you get the munchies, you need some pizza. Now, who are you more inclined to give money to? The weed and pizza guy, the beer guy, or the God bless you and I'm a veteran? Here's what happens. We come up to that street light. The street light is red. We have to stop. The person is there with the sign. We don't make eye contact. We don't. We look at the light, and in our head, this is the conversation. Que cambie la luz, que cambie la luz, que cambie la luz, que cambie la fucking luz. I hope the light changes. I hope the light changes. I hope the light changes. I hope the fucking light changes quickly because I feel uncomfortable, you see? What happens? The light eventually changes. Some of us might give something. Some of us don't. The majority of people don't. We drive by. We arrive home. 7 o'clock news. There's a story on the 7 o'clock news. Someone in the park did harm to a dog, and the dog is up for adoption. And quickly, there's a line of people adopting the dog. And on the way to adopt the dog, they're at the street light, que cambie la luz, que cambie la luz, que cambie la luz, que cambie la luz. And or stepping over people who are experiencing homelessness. That is dehumanization in process. And if you haven't felt that and seen that, maybe we should be a little bit more honest with ourselves. Recently, I was at a stoplight. Dude is there. He has a sign. I look at him, looks at me. I usually, motion high, that sort of thing. He did one of these. And I saw the Apple sign. I said, shit, he has a phone. And then I caught myself. Why shouldn't he have a phone? Why shouldn't he have a phone? I did this presentation recently at another state. And then some of the men who were there experiencing homelessness, they came up to me and said, add this to your presentation. Many times I was standing there with my sign. They stopped, they opened the window and said, this is for your dog. Don't use it for anything else. Dehumanization in process. How do we wrestle back our humanity when dealing with these issues at the community level? That becomes the question, or one of the questions. To what Dr. Torres was talking about, it's not enough to be trauma-informed. We need to be social justice informed. If we don't understand these issues from the perspective of disparities and equity, what are we doing? We need to be trauma justice informed. People have been impacted by these issues in many different ways. No, mental health and substance use disorders, they don't impact people in the same way. And our system doesn't treat them in the same way either. We need to be social justice informed as well as trauma informed. To talk about some solutions, strategies, and outcome, how many of you have seen this depiction? Hands, right? You've seen it. Okay, good. Others might not have. When you see equality, what do you see? Different heights, trying to watch the ball game, same boxes. Can everybody see the game? No. And before anyone says looking through a peephole in the fence, there is no peephole in the fence. The smallest person there cannot see the ball game. Do you think equality exists? When I ask that question, when we have more time and I enter into conversations, there's usually people who say no, and then there's some people who say, yeah, equality exists. Depends on what you're talking about. They begin to slice things up. Let me just say this. Equality exists in the minds of people with power and privilege. Equality exists in the minds of people with power and privilege. That is a reality. Those are the people who get up in front of a group and says, well, I am self-made. Let me tell you how I did it. And they go about, spewing their resume and how they did everything they did. And I treat everybody the same. Yay! Who taught you how to read? Who taught you how to walk? Who bathed you? Who did all of those things? Who taught you? There's no such thing. Equality exists only in the minds of people with power and privilege. Bring you all the way to the end. Reality. What does that look like? And before anyone says, the smallest person there is digging a hole underneath the fence to get underneath the fence and watch the game, that is not what it's saying. What it's saying is that some people were born in the ditch and are born in the ditch. And no matter how hard they work, they're going to be in that ditch. So this whole idea of if you just work hard enough, because I know people who have 3 and 4 jobs. They work harder than I do. They don't leave like this and come back home the way that I look, and they will never make the amount of money that I make in one day. So don't give me the hard work spiel that if you just work hard enough, you're going to come out of that. Some people were relegated to the ditch because in order for us to live the way that we live, there has to be people who are really poor and indigent. There just has to be. That is a reality. The person in the middle, the reality has stayed the same. And then there's this person with 7 boxes instead of 1, when, to begin with, didn't need not even 1 box. And so those of us in the room and, people in public health and social work and that sort of thing, we, oh, yeah, because those people have a lot of money and this and that, and we go there. But I would venture to say that all of us in this room have several boxes. Think about your gender, your race, your ethnicity, your education credentials. Think of all of that. All those things end up being boxes. The question is, how do we use our boxes to help people and to address issues of equity? That then becomes a question. And there are plenty of people who have a lot of boxes who are white billionaires, not as many as I would like to, but they do the right thing. There's one person who comes to mind. 2016, tax reform, said, I don't need a tax break. My secretary does. She pays more in taxes percentage-wise than I do. You know who that was? Anyone? Buffett. Buffett said that, right? White guy, billionaire. Not everyone who has a lot of resources is out for themselves and themselves alone. And there's plenty of people. Remember the Morehouse commencement speech? You remember the guy's name? Because his name is not Buffett, right? African-American guy. Came before the student body and the graduating class and said what? All of your student debt? Greatest commencement speech ever. What's his name? No one knows. David Wright, right? Now everyone wants to invite him. We tried to invite him here, but he didn't come. You follow what I'm saying? Not everybody who has power and privilege is out for themselves. Now, I take you to the middle. Most of us work on boxes, the distribution of boxes. And I would venture to say that most of you in this room saw the depiction and said, oh, the middle is where it's at. The middle is where it's at. Because we get to distribute boxes in a different way. They're all happy, hands are up, fists are pumped, and people are really happy and they're watching the game. And if you saw that and you didn't see the greater issue happening here, then you missed the boat. Because the issue is not the boxes, the issue is the fucking fence. You see? If we don't tear down the fence, then we will forever be dealing with the distribution of boxes. Now, all of us have an important role to play with boxes. I play with boxes all the time. I can call a clinical supervisor, get people into treatment. I have power and privilege that I use in that way. But if we don't work on the issue of the fence, then we will forever be chasing our tails. This is about advocacy and policies, people. Because the people standing on boxes, if you ask them where they want to be, is inside the bleachers, paying the $12 for the stinky hot dog and the $15 for the beer. They don't want to be marginalized on the outside looking in. You see them as seeing over the fence, but when you look from inside the fence out, what you see are their faces and their faces alone. And we should think about this piece in a more comprehensive way. And not just in that myopic view of what the problem is. If we think that the problem is watching the game, then we will come up with solutions of watching the game, which end up being the boxes. If we understand that the fence represents policies and procedures, all of those deliberate policies regarding mass incarceration, for example, then we will stop blaming people for the conditions in which they live in, and we will have a more comprehensive outlook in terms of what's happening with people. Another tool at our disposal, in addition to thinking about issues of equity, are the enhanced national class standards. How many people, show of hands, know about the class standards? There's a few people. They've been around for a while, developed by the Office of Minority Health. These days, you can't get a grant to provide direct services unless you sign off on that you understand and will implement the class standards, right? Here is the principal standard. Provide effective, equitable, understandable, and respectful quality of care and services that are responsive to diverse cultural health beliefs and practices, preferred languages, health literacy, and other communication needs. That's the principal standard, right? This is just a real quick overview about this stuff. There are 3 broader themes. Theme 1 has to do with governance, leadership, and workforce. I'll come back a little bit later to that, but this is a look inward to your organization. What does it look like at all levels, right? At all levels. Theme 2 has to do with communication and language assistance, many of the things that we've been talking about here. Hasn't been mentioned a great deal, but I'll just mention it now. When we speak about Hispanics and Latinos, most people say, oh, they speak Spanish. Not everybody speaks Spanish. Luis talked about that, right? Luis mentioned the fact that many of us speak English and English only. But there's people who speak Brazilian, a form of Portuguese, right? From Brazil. There are people who speak indigenous languages all across this country. So not all Hispanics and Latinos only speak Spanish. And by the way, we speak different forms of Spanish, right? I'm sitting over there with a bunch of Puerto Ricans at this table, right? And we don't all speak the same. We don't, right? And we're Puerto Ricans. Now imagine if you're from El Salvador, from Nicaragua, from Mexico, from Colombia, from Uruguay, Paraguay, from all of these different countries. The work that we need to do is, if you are seeking to serve the Hispanic or Latino communities, what does that community look like for you at the local level? And to get away of painting with a broad brush, that everyone looks the same, acts the same, and speaks the same. The third area here talks about engagement, continuous improvement, and accountability. So it's not just implementing the standards, it's a process for evaluating them moving forward, not as a one-shot deal. Quick overview on the class standards. We're going to talk about prevention. It's important that we understand SAMHSA, the Substance Abuse and Mental Health Services Administration, which they need to change their name, by the way, right? Substance Abuse and Mental Health. Here is the prevention framework and the steps, right? And so if you look at the center of it, it has sustainability and cultural competence. Because it's cultural competence and sustainability should not be a one-shot deal. But what are the different steps? Assessment, capacity building, planning, implementation, and evaluation. And so I'll come back to this a little bit later in terms of engaging with communities around implementing what we call the SPIF, the Strategic Prevention Framework, right? So, in terms of involvement from the community, if you think about Hispanic and Latino communities, what do we need to do, right? We need to think about the organizational culture. So what does the organization look like? Who's on the board? Who's the executive director? Who's in senior management? Who are the staff? And we know from research and from reality that the upper that you go within institutions and organizations in the US, the wider they are. So how can you claim to serve a population that your leadership knows very little about? And then you're most concerned with having a receptionist that you think is bilingual. No one knows, or she speaks something because we heard her speak and she brings in that funky food, right? And we think that she speaks that other language. That is not enough. That is not enough. That hurts human beings, right? That hurts human beings. So what does that look like in practical ways? Staffing should be representative of the community and of the populations we seek to serve. The specific subpopulations, again, there are many Hispanic and Latino subpopulations across the US. And then the services. Are they accessible? Are they at the community level? What do they look like? Are people comfortable? Do they know? How can they get there? Is there transportation? Or is it this system that we have, that we sit behind a desk and you come to me and you tell me what your problem is and then I'll help you? Or truly are our services community-based and embedded in community and have representatives of the community delivering those services as well? When we look at community involvement at all levels in the SPIF, we're talking about assessment. How do we engage community members if you're doing prevention work? And this has been done across the country. It's not that it's impossible, it's more difficult. But the more difficult it is, the better outcomes we have. How do we engage people in the assessment process? And not just assessing them, but them in a process of assessing the community and what the problems are in the community. I guarantee you that the results of that assessment look different when community is involved. Capacity. How do we mobilize or build capacity to address the needs? This includes people from within that community, right? Is to develop the capacity of that community to address their own issues. Planning. How do we develop a comprehensive strategic plan? This again includes involving the community in that process. We should never underestimate the capacity of the community to engage in that process. If we do it at the detriment of outcomes. Implementation, the delivery of services should be done and have better outcomes when they're done with the community that we intend to serve. And evaluation, how do we monitor, evaluate that things are happening the way that they're supposed to be happening? And what is the community's role in that process? There are some challenges to this process, though. They include a workforce crisis. In substance use disorders and mental health, the majority, and this has been documented ad nauseum, right? The majority are baby boomers and white who are retiring soon. They're not reflective of the priority populations that are coming through the door. And so we have an issue there. And we have issues with trust. And I would argue that it's not just trust, it's healthy fears of government institutions. Hispanics and Latinos and other people of color have healthy fears of government institutions. And by definition, all of us in this room work at organizations that are extension of government because we receive public funding. And so people don't trust us that well because they have experiences at community level, historical experiences that speak to these issues. And if you don't believe me, learn about Tuskegee. Learn about La Operación, forced sterilization of Puerto Rican women. Learn about how government has, in the name of health and public health, has done certain things that impact community. So trust is a huge issue, not to mention issues of immigration and migration that we've been talking about all morning. There are issues related to culture, languages, and terminology, and I would say that we should not turn into those are the barriers of the Latinx or Hispanic communities. Those are our barriers. If I receive money, if I applied for a grant saying that I'm going to serve X community, and I don't understand their culture, that is my problem. I have the barrier. If I said I'm going to serve this community and they speak Haitian Creole or Spanish or any other language and I don't have staff, that is my problem as the organization. We shouldn't then place that burden on people and say, no, you're the one with the barrier. That's short-sighted and problematic. And then those of us who have been to institutions like this one, fine institution, right, who've learned the terminology of the privilege, need to be very careful not to go into communities to further alienate people with behavioral health disparities, social determinants of health, and all of these other terminologies that we like to hear ourselves talking. People at the community level deserve and want to be understood, and they understand these complex issues. But if we try to speak over them, we will accomplish that really quickly. There are knowledge gaps. Not everyone understands the issues at the community level, but that doesn't mean that they don't have the capacity to learn. There are competing priorities. You might go into a community and say, I have an HIV prevention program, or a substance use disorder prevention program, or hepatitis C prevention program. And those folks might be saying, yeah, but I don't have a place to live. Right? So we need to understand that our priorities, because of funding, might not be the priorities of the community because they live a different reality. They live a different reality. But that doesn't mean that they're not willing to work on these issues. And there are budget constraints, and we know that, right? As well as other challenges to involving community. But that doesn't mean that it's not possible, right? We must also talk about the benefits of community involvement. If we have on-point delivery of services, then culturally we will be on point, right? Capacity building for the organization, for the staff, and for the community. We will develop capacity if we do this in a comprehensive way where we partner with communities. There are partnerships and sustainability that will happen over time. There were mentions here that most of the work that's being done with immigrants in this country are being done by faith-based organizations. It behooves us to partner with those faith-based organizations because they've been doing this work for decades with very little recognition and money. When we build those collaborations, then that work is sustainable over time, and we know that for the most part, we work with grants that last anywhere from 3 to 5 years. So we should be thinking about sustainability. Increase community readiness. Again, when we engage the community, they will be more at the ready to deal with issues that come up in the near future. There will be changes in community norm when we do this work well. We will build equity and we will impact issues of disparities. And there will be career ladders for people from my community who are at the ready, who want to help, who want to work in these areas. So this benefits everybody. The question is, we do a great deal of talking by way of empowerment. And someone told me a long time ago, you know how you empower people? You give up power. You get out of the way. Many of us think that empowering people is just feeding people. And feeding people is a good thing, but 2 hours later, they'll be hungry. Right? This metaphor around teaching people how to fish as opposed to just feeding people, that comes to mind when I think about these issues. We need to understand better evidence-based practices, right? And these refer to prevention programs, strategies, and policies that have been rigorously tested under research conditions and found to be effective in changing behaviors and attitudes. And there's a whole registry of evidence-based practices that SAMHSA has and other federal agencies have. And so we need to ground our work in, whenever possible, in those evidence-based practices, right? There are some practical steps here in terms of reaching out, doing the research, understanding what the evidence-based practices are, how to utilize them, how to select them, those sorts of things. And there's plenty of evidence of effectiveness when we go into those registries and we read who developed them, with what populations, what were the outcomes, and those sorts of things. But there's some challenges with that as well. So the first step is to know which ones they are, know the priority population that we're working with. In this case, we're talking about Hispanics and Latinos, and then going about reviewing and organizing, narrowing the options, and selecting an approach. Right? That's part of the process. Once you have selected whatever that approach is going to be, then there's some critical questions that we should ask, right? Is this the best fit for the Hispanic or Latino population that you're working with? Is this the best fit? Remember how these evidence-based practices come to be. They're usually done in another part of the country, another part of the state. They're evaluated, the population looks like this, and then they say it's replicable to other populations. Sometimes that doesn't hold ground. If there are no evidence-based practices available, what are best practices, promising practices, emerging practices, like Dr. Luis Torres was talking about earlier, right? Then how do we employ those in their implementation? That sounds simplistic. How many people here have ever been trained in an evidence-based practice? Raise your hand. There's quite a few people. So there's something called adaptation and tailoring. If you've been to those trainings, they give you the core elements, right? Here's the population, here are the core elements, this is what you do, you need to maintain fidelity, and then you should do some adaptation and tailoring. If you're like me, and sat in many of those, right, then there's few people in the room who raise their hand and say, I work with the Hispanic and Latino population, I want to know if this is effective with that. Oh, you need to do that on your own, because we don't have room in this training to be able to do that. So we send people home, right, with that manual and with the training that they receive, but they need to do the adaptation and tailoring on their own. Maybe if you're lucky with some technical assistance and support from the trainers. The question is, are your staff adequately trained and understand the core elements of the intervention? That was one of the first questions. What mechanisms are in place to maintain fidelity with the intervention? And are the materials in languages that people can understand, that the priority population that you're talking about can understand? And I'm not just talking about written materials. I'm talking about other things that we utilize in evidence-based practices, because many people don't know how to read or write, and so we come up with these evidence-based practices that require that people have to learn how to read or write. Different things to take into account, as well as the cultural considerations that I was talking about earlier. So when we talk about implementation, what does accountability look like for the organization, for the staff who are implementing it, and for the community members who are participating in it. What does accountability look like at all levels, and not just at the frontline level with the staff who are implementing it? What does fidelity and cultural adaptations look like? That takes time and practice and knowledge. And what does an effective evaluation feedback loop look like? Most evaluators don't look like the communities that they're evaluating. I'm going to be very specific here. Most evaluators are white, and many are male. And they collect data, and they publish whatever it is that they publish, and the community on the front line ends up with what? Oh, we did the intervention there. There needs to be a feedback loop. That's a responsible way of engaging people in evaluation, where people have the capacity to understand and know those things when we speak with people in everyday language about these issues. And then how do we do sustainability? How do we do sustainability? From day one, not as an afterthought. Not as an afterthought, right? Dr. Torres talked about these fancy terms that come around from time to time, and I'm going to use one of those once again. The social determinants of health, right? If we continue to only advocate for a certain point in the continuum, then we will get the results that we get. For example, do we need treatment? Of course we need treatment. But do you want your kid to have a bed available when he or she needs it? Or do you want your kid never to have to need a bed? And if your answer is yes to the latter, like I believe that most people do, then we need to embrace issues of prevention. Because just having enough treatment beds where there is not a waiting period doesn't deal with the issue properly. We have to deal with prevention, intervention, treatment, and recovery supports. And some of the most controversial things that are happening right now in the field, particularly of substance use disorders, there's a lot of people who get in the way of progress. There's something called harm reduction. Familiar with harm reduction? How many people in this room use harm reduction currently? Raise your hand. Not everybody did. Did you put your seatbelt on when you came in? That's harm reduction. Did you stop at the stoplight? At the stop sign? I stop maybe 90% of the time. Did you stop at the stoplight? That's harm reduction. Harm reduction has been around for hundreds of years. I get controversial in two areas. Ready? Sex and drugs. Sex and drugs. That's where harm reduction gets controversial. Remember HIV, AIDS, 80s and 90s? We give them condoms, we're condoning sex. The opposite is true. Evidence, research tells us that sexual activity goes down, sexually transmitted infections go down, and the opposite is not true, that everyone's going to be having sex in the porch and everywhere else, right? So we should get over that. We have research that says that, right? But it's high and mighty people who, by the way, for the most part, maybe don't even need condoms because they don't have sex, but they're against other people having condoms, right? Doesn't make a lot of sense. I didn't think that I was going to get an applause, but we'll take it. And so in the area of drugs, what are the most controversial things now? Syringe access, right? Used to be known as needle exchange, right? Because initially what people, they're giving out needles and they're condoning drug use. Well, they're not. Those are the people who are engaged with people at the community level, preventing disease, and we have evidence to prove that. They are engaged with people and doing outreach and developing trusting relationships with people because dead people don't recover. Have you met the people who say to you, I want to use drugs, get the hell out of my way, I am not ready to stop? There are such people in that space and place that are called pre-contemplators, right? There's some of us in this room right now who are in pre-contemplation. We're no different from anybody else. How do I know that? You know that. You went to lunch. You know that. You've been thinking about going to the gym. Either you're going or you're not going, or you don't want to have this conversation, but you're either in pre-contemplation, contemplation, preparation, action, or maintenance, and that is what people who use substances are into. So we have plenty of people who are in pre-contemplation. We should embrace harm reduction methods because we know that the evidence and science say they work. Huge one right now is around safe injection sites. Right? In Massachusetts, we have places where people can come in and after they use, come in and they're monitored by a nurse, a doctor, and outreach workers are there and try to get people into treatment, that sort of thing. In other words, we need to either embrace practices that are based on science and evidence that work, or we need to simply get the hell out of the way. If you're one of those people that can't support any of this stuff, let someone else do it. Because maybe harm reduction is not good for you, but for other people, it can save their lives. And again, dead people don't recover. And once you're infected with HIV, we have no cure for that, right? And so we need thinking outside of the box that is not just in the mainstream. I got the 10-minute warning a few minutes ago. And so, according to my time, it's 2:20. So I have a couple of minutes for any question, comments, pushback, any of that. Before we go there, I just want to thank you for coming, staying, listening to us, thinking. I see people taking notes, that sort of thing. We don't pretend that everyone's going to agree with everything that we say. I know that that's not true for me either. But I want to thank you for coming and listening and being a part of this. Thank you very much.